Okay, so today is Tuesday, September 29th, in a year that seems to be going by incredibly quickly and incredibly slowly at the same time. Oh, and I realized, Carol, I got do you have access to the Canvas, Carol?
Yes,
You do?
yes.
Okay, good. All right. So I've recently uploaded the Class 5 notes. So what we'll be looking at today is basically going over conditions involving the neck. So looking at the Canvas site, let me look at the modules here. So yeah, there's a lot of stuff. So what we'll be using today is the Class 5 Head and Neck Fall PowerPoints. Did I upload the notes? Maybe not. Let me upload the notes right
No,
now. Okay, let me do that right now. I'm
thank
going to record.
you.
Let me pause the recording here. Here we go. Now we're recording. All right. Okay. Thank you. Thank you for keeping an eye on that. If you see that again, let me know. All right. So any questions about any of the previous material? Okay. So I just want to remind you very briefly, it took me, a little while to figure out the balance method, that channel balancing. It took me a while to really get the channel treatment strategies, the sinew meridian treatments, the primary meridian treatments where you're doing certain movements and then treating the tonification points. And if they don't work, treating the sedation points, going through the sinew movements, learning the 5 to 7 systems of Dr. Tan's balance method. It takes a while to get into that and to practice. You only have to learn by practicing. And that's why I would say, in your abundant spare time, put a few people through the movement tests and massage certain points and see, what you notice. Or have them massage certain points and see what they notice. You can do it over Zoom or something, or over FaceTime. And, the way I structured the course, again, is I just want to say is I was responding to previous evaluations that said it was really hard to learn the theory while we're going over the different body parts. So that's why I front loaded all the theory. You've got it all there. I'm super happy to talk to anybody at any time. If you have questions about it, if I'm busy, I'll just say, okay, let's reschedule. But I'm happy to go over any of this with you at any time, okay? I'm always at your disposal. All right. So by the end of class today, you'll have a basic understanding of what motor points are, what a trigger point is, what a manual muscle test is, what a phasic muscle is, what a postural muscle is, what spondylosis refers to, right? And then you're going to have a very basic understanding of the 2 major categories of neck problems, and then within them there's couple types each, and how to identify them, how to assess them, and how to treat them, right? And then if time, we're going to go over like TMJ with all of that as well, okay? All right. Any questions about the agenda? Okay. All right. So having the opportunity to work with Bob Duggan for a long time, I co-taught with him for about 6 years in the treatment planning course, and shadowed him at Penn North when we started that. A lot of what he said, and also following him around at a lot of his talks. And I remember him saying something like, neck pain has never walked into my office. Right? That was probably one of the more normal things he would say. He would he was like, neck pain has never walked into my office. There's only, he would say, it's only it only comes attached to people who are with complicated lives, right? So, and I remember JR saying, don't ask, what kind of symptoms does this patient have? Ask what kind of patient has these symptoms. And even though we are discussing this on a relatively physical level, which I think gets short shrift. And I think that there's so much information out there about it. My goal is to shorten your learning curve, to go through a lot of the available information and consolidate it in a way that's going to allow you as a beginner to begin and start treating people effectively, and also at the same time having the added benefit of knowing what you're doing while you're doing it, which is not what I had when I graduated. I was great at making rapport, right? And I could clear the heck out of IDs, but what I want you to remember is in the larger context with which all of this information is given you, is always remembering that this is a whole person, that, it could be anything from some aspect of their life which is interfering with the flow of qi. If you remember way back in the 5th trimester with the treatment planning class, and I talked about like that qi flow diagram, right? There's the qi, and then the organs, and then the blood, and the tissues, and the substances. And, basically on an emotional level, if they're kind of stuck in some kind of story over and over and over and over again, it's like the dripping faucet. Eventually that will constrict the flow of qi and blood, and that over time will result in some kind of dysfunction, right? Malfunction, and a disharmony process, right? And then over time, symptoms are going to result, right? So sometimes neck pain is from a physical source, and sometimes neck pain, like anything else, is from a non-physical source. So just keep remembering that a person's lifestyle, person's environment, both the environment around them and also the environment in here, plays a big part, especially in what we're going to cover today, which is neck pain, as well as TMJ and back pain. But pain can be anywhere, all right? It's important to remember that. Pain can be anywhere. So remember your SOAP notes, right? Subjective, objective, assessment, plan, right? Subjective, you guys know SOAP notes, right? I don't have to explain SOAP notes to you. All right. Let me just take a look at my notes here. So I'm a big fan of distal points. As I've supplied to you a little image, or I think maybe even 2 images of what's called the homunculus, which is what would a person look like if the person's body parts, if our body parts reflected the amount of neurological density devoted to the different body areas. We would have huge faces, we would have monstrous fingers and hands, we would have huge toes and feet, pretty large forearms and lower legs, tiny chest, tiny back, very small abdomen, enormous genitals, really big sensory organs, and especially the face. And so, the distal points give us a lot more bang for our buck, right? I think the ancients were able to kind of tune into that. So that's why I'm a big fan of doing distal points first. And it makes sense that the command points are from the elbows down and the knees down. So again, there are times when I combine local points, but generally I work from distal to local. That's my overall strategy, regardless of what area of the body I'm working with, regardless of what condition I'm working on, whether it's asthma or insomnia or neck pain or TMJ. The Ling Shu is clear, though, that the exception to distal points is issues dealing with the head and the face. And they do encourage us to needle points on the head and the face. And interestingly enough, according to the homunculus, we have a massive head and face. So again, I think the ancients were tuned into this. So if people ask you, like, why are you doing so many points on why are you doing so many of those awful, painful points on my fingers and toes? And you can show them the homunculus. All right, so let's just do a brief review of terms, and then we'll get into the conditions. So a motor point, it's important to be clear that there's no single agreed upon established definition of a motor point. And a lot of times when people are talking about motor points, they're talking about 2 things. They're talking about an area on the skin, and they're talking about an area that's deep in the muscle, right? So if you were using a TENS unit, which has like a patch, right? that's placed on the skin, or like when you go to the doctors or the hospital and they put those sensors on you, right? Right. They're connecting to the covalent response that's higher at certain spots on the surface of the skin. When I'm talking about motor points are where the largest motor nerve enters the muscle, either at the muscle belly or close to the terminal ends, that has the most powerful effect on the contraction of the muscle, right? So in a sense, it's kind of like where the lamp plugs into the wall, right? So your lamp is the muscle and that motor nerve is the plug, right? And what it's plugging into is the peripheral nervous system that leads to the central nervous system, right? The motor nerve system. You've got sensory nerves and motor nerves, right? Sensory nerves help us to sense, like is this proprioception, like, you know, it helps us distinguish between a nickel and a quarter in our pocket. And then you've got motor nerves, which help us to contract the muscles so we can engage the muscles so we can perform activities. So an MEP, a motor nerve entry point, is basically where the motor nerve first enters, and to a largest degree enters the muscle belly, or where the terminal end of the motor nerve is located at the motor end plate, which is also known as an intramuscular motor point. So the important thing to remember for your sake is this is a place that's very bioelectrically active, where I can interface with the muscle to interrupt any kind of inappropriate signal from the central nervous system that's either having it contract too much, right? If you think about like the old time movies, which you had film like running past a light, right? And they used to call them flicker shows because if you slow it down, you can see it flickers. So imagine like this flickering of the motor nerve, flickering the muscle to contract, you know, many times a second. And that's what we would call a muscle spasm or muscle tension. Similarly, maybe the signal isn't reaching the muscle well enough to engage it to fire, right? So it's disengaged. So an overengaged motor nerve, right, leading to spasms, muscle tension, tightness, that's a shortened overactive. It's shortened because all of that contracting is shortening the muscle, right? It's in a hyper state of contraction or in a state of hypercontraction, right? So it interrupts that signal, or it could be lengthened and inhibited and therefore weak. Although I don't like to use the term weak because even a muscle that's overactive and shortened and in spasm is going to be weak, right? A muscle is only as strong as its ability to relax. So you may have too much signal coming from the central nervous system saying contract, 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 right? So it's shortened and tightened, right? Shortened and overactive, right? It's contracting too much, or it's lengthened and weakened and underactive and inhibited. Sometimes it's called inhibited, right? So it corrects the signal coming from the central nervous system, right? By engaging or activating a lengthened, inhibited muscle, or relaxing a tightened and shortened and overactive muscle. Okay, so this is basically the point where you can wake up or relax a muscle. Okay, does this make sense? And this is different than a trigger point because when you needle a motor point, you're not going to get much of a referral pattern, right? Trigger points are a little bit different. A trigger point describes a taut band of skeletal muscle located within a larger muscle group, okay? And these are going to be tender to the touch. They're going to be ashi, right? There's going to have some kind of referral pattern, either like numbness, tingling, pain, discomfort, ache. Motor point might be sore, but it's going to be sore at the spot, right? Not all motor points will be ashur when you palpate them. They often will be, but if the muscle is very lax, if that muscle is like weak and inhibited, excuse me, over lengthened and inhibited, it may not necessarily, it may actually feel good, right? And if you think about, you know, hurts with pressure, that's more of a sure condition. Feels good with pressure and massage, that's a jus empty vacuity condition, right? So sometimes the motor points, they're like, oh yeah, man, that feels great. You know, especially like small intestine 11, where you're like right there in the middle of the infraspinatus muscle. Like, I think if you're ever courting anybody and you want to get them to like fall in love with you, like massage the small intestine points along the scapula and then feed them and they'll be yours, right? Especially small intestine 11. All right. Okay. Is this on? Is this on? Hello? So anyway,
I have a
As
question.
somebody who's single, I appreciate that advice and I will keep it in my back pocket for future use.
I just like the word courting.
yes, I don't know what else to dating. I don't know. I'm like, I don't know. What can I say? I'm old. But yeah, right. Who courts, right? Nobody courts. It's like,
So I understand, I have a question. I understand like the indication of like how a shortened muscle would affect the body. Like what would a lengthened muscle feel like? Why would you need to wake it up?
because it's not engaging, and therefore it's not providing an antagonist role. It's not working its antagonist role for the agonist muscle. So like say my bicep is shortened and overactive and my tricep is lengthened and inhibited, this is going to be now susceptible to injury.
Oh, so do you do both in a treatment? Like,
Sometimes
okay.
I do. Again, you'll do manual muscle tests to see, or they might, because this muscle, if it's lengthened and inhibited, it can still ache.
Okay.
Yeah, because when you try to engage it, like to do something, right? Or you're doing something else and it's not engaging to be the antagonist to this, you could get like you could get pain in that area. So it could be pain or dysfunction. You're more likely, but this is a great question, Naz. This really gets to the heart of something, which is more often than not, you'll have pain in the shortened overactive muscles, and you'll have like not so much pain, but like a loss of function, which then leads to pain in other areas.
Okay. I
So
totally
thank you
get
for bringing it
it.
up. That's a great that's a great question. All right. So trigger points basically are where the fascia around a muscle has become overstressed and there's some kind of inflammation, and then the fascia lying on top of the muscle isn't like loose and can't slide, right? So there's an adhesion there, and that inflammation creates like a stickiness, right? And so just like if you're trying to move in a shirt that's like super tight, right? One is you might have limited range of motion. The other is imagine you've got nerves throughout your shirt as well as your skin underneath the shirt, right? Like maybe your skin underneath the shirt is the muscle and your shirt is your fascia, and you go to move and you can't move, it's inhibited, right? You've got like inhibited range of motion, but then it stimulates and fires off all these like nerves that create pain, right? So it can lead to like an aggravated trigger point, or trigger points are created when there's been either some kind of injury or some kind of deterioration, like overwork, repetitive stress disorder, and that leads to an increase in muscle stiffness and tenderness and a decrease in range of motion. But the trigger point, you'll know it's a trigger point because you'll palpate a certain point of tenderness and there'll be a radiating sensation. And this is where Travell and Simons, I think it's Simons, have these like two big thick books, one on the upper body and one on the lower body, on like myofascial trigger points. And you know, it's a nice text to have. A lot of that is on the internet, right? These are, you know, also Ashi points, right? They're always going to, trigger points always going to be an Ashur point, right? But not all Ashur points are trigger points, right? Some could be like a local phenomena. right? It could be just a simple local stagnation of qi and or blood in a small area that's creating the ashur. Like sometimes motor points are ashur, right? But a trigger point, this is where like this is like a point of like intense adhesion between the fascia and the muscle, okay? And supposedly, when you needle into that, you're breaking up the adhesion. And I think just the fact that like the needle is metal is somehow interfering with the bioelectrical or stimulating the bioelectrical field of the fascia, which is predominantly made of collagen, which not only is a phenomenal conduit, or what do you call it? Not a conduit, conductor of electrical energy and bioelectrical energy. Collagen has actually been shown to produce an electrical field. So I think that that's interesting. Like, I think, you know, this has a lot of implications on what qi is and, you know, where you find it in the body. So, you know, we actually have an electrical generator, you know, in our fascia. So I think that that's really interesting. So anyway, these are different types of points that you can utilize in the P part of the SOAP, in the treatment plan, which are local points or relatively local points in the area of the problem that can be used in conjunction or instead of motor points, or it can be sort of like your local, sort of a local middle or local distal treatment principle, treatment plan. You know, these can be these can provide like local points, right? And sometimes people really like this. There's some people that really want you to treat locally. And so this is like a good way of doing that. All right, and you can look these up in different texts. I didn't want to go like too much into that. All right, so we'll just cover a couple of other little definitions and then we'll take a break. So manual muscle test is basically a passive or active test that you'll do, mostly passive tests, mostly active tests where you'll you'll move a body part and then against some kind of resistance provided by the patient, right? So it's basically an examination also of, you know, the condition of the nerves leading from the nerve root from the spine coming into a muscle or a group of muscles. So what you're looking for is weakness. You're looking for what do you call it? A replication of any kind of pain, a replication of any kind of like stiffness or discomfort, right? Some of them may even indicate like a lesion on the spinal cord itself or on the nerve root, right? It may give you information about like what's going on with the discs in the intervertebral space. And it give you information about like what level of the spine where that lesion may be present. In more simple terms, basically what you're looking for is you're putting them through an exercise. You're putting the patient through a resistance exercise. Like you're going to be moving their body one way. They're going to be resisting that movement in the opposite direction. And you're looking for a recreation of either pain or discomfort, or you're looking for weakness. I have recorded like a boatload of manual muscle tests. I am in the process of editing those. I have put a few up on the YouTube channel. There's one on the neck extensors as well as some orthopedic evaluations. So you can look through those. And I'm going to be, hopefully tonight, I'll be uploading some more maybe tomorrow, okay? So basically, again, I did these so I could give you guys like an actual image of like somebody doing it, because a lot of what I found online wasn't that great. I do use manual muscle tests quite a bit. I don't know why, but for some reason it's like one of those weird things that like I have a hard time remembering. So I have to keep going back to my book over and over and over again to like, oh yeah, right, this is how you test this muscle. For our sake, the manual muscle tests for the head and neck, it's hard to isolate a lot of the single muscles. There's a manual muscle test that we'll go over for the SCM, the sternocleidomastoid. We'll go over the one for the scalenes. We'll go over the one for the neck extensors. The one for the neck extensors as a group, because they're all bundled in there, very close proximity to one another, is already up on the YouTube channel. So if you, has anyone gone to my YouTube channel yet and looked at any of those?
I have.
Okay, yeah. So, you know, again, it's not required, but it's a nice way of seeing, you know, an example of what that looks like and really how simple it is. It's, hopefully it takes a lot of the, you know, hesitation about doing them out, you know. All right, so manual muscle test is basically, I'm doing a test on a muscle to see if it might be involved in the problem. And that might show up as pain, stiffness, discomfort, or weakness. All right, so just a few more definitions, we'll take a break. So there's postural muscles and phasic muscles. Very simply put, like the name suggests, postural muscles help us to maintain our posture, right? These are the ones that are more likely to become shortened and overactive, and therefore probably the ones that are more involved in any kind of pain, in this case, neck pain. I've highlighted the ones in your notes. The postural muscles that we'll mostly look at are the levator scapulae, the upper trapezius, and the pec minor, the pectoralis minor. Remember, there's minor muscles and major muscles. Minor muscles always sit on top of the major muscles. So if this were my back, right, the rhomboid minor would go here, the rhomboid major would be a larger muscle underneath of that, right? Pec minor goes here, pec major goes here, right? Teres minor goes here, teres major goes back there, okay? So minor muscles always set on top of major muscles. And I don't know why. Was there a question? Okay, I don't know why, but more often than not, it seems like the minor muscles are usually the ones that are responsible for the pain involved in most of the conditions that I treat. Where there's major and minor, I don't know why. Maybe because they are smaller, they're more susceptible to micro tearing or damage. You know what I mean? Like, imagine trying to break like one small stick and then you put like 10 sticks together and try and breaking those. It's much harder. I think it's the same principle. These are the ones that help us maintain our form against gravity, right? So these are the ones that are also the most susceptible to dysfunction and atrophy when people are in space. So in case you go into space, make sure you work your postural muscles. Yeah, very important. Okay. All right. So,
I'm sorry. Did you say they atrophy more or less quickly than phasic muscles?
Without gravity, they would be atrophying more. Yeah.
But with gravity where we live, they atrophy less quickly?
I don't know.
Well,
think
that's what the notes, that's what I have here. So but I think maybe I misunderstood.
Yeah, they atrophy in terms of, with gravity, they atrophy less quickly than phasic muscles.
Okay.
Yeah.
Okay, thank you.
In gravity. At least Earth's gravity, yeah.
I'm going to focus my work on gravity environments.
I think that's important, I think, yeah. I specialize in gravitational dysfunction. People are like, I live in gravity. All right, so phasic muscles, you know, obviously they're the ones that help us to move. In this case, it's the rhomboid minors, to some degree the rhomboid major, lower trapezius muscles, right? The deltoids, the triceps. These are the ones that kind of like spring into action, right? So these are the ones that are going to be, there's going to be like more dysfunction upon some kind of movement, more often than not. Whereas postural muscles generally hurt like I'm just sort of sitting here and they're aching, right? That's not a hard and fast rule, so don't use that to make hard and fast distinctions, okay? because more often than not, like when people coming into your door with neck pain, it's going to be more often than not, it's going to be the postural muscles that are the ones that are most involved with their pain most of the time, unless you're working like with an athlete. But if you're working like most people that like sit behind a desk or behind a camera, it's going to be more of the postural muscles. All right, spondylosis. Basically, it's a pattern or a syndrome of deterioration of the intervertebral discs or other anatomical features like the facet joints, but mostly they're talking about deterioration of the discs or the vertebrae itself that are around or involved in the facet joints. So each vertebrae sits on top of every other vertebrae, and where they make contact on the sides are these faces, these flat parts of the vertebrae, and those are called a facet, like the facet of a diamond, like the face, right? And so, but basically, more often than not, what we're talking about is anyone over 40 who is living in gravity, their discs, which are like a big, like a tiny jelly donut, right? You've got like the outer part, which is the, and it's so funny, like I say this about 8 times a day, and of course I'm blanking out while we're on the recording. Annulus, right? There's the annulus, which is like it's the tough part of the jelly donut. It's the doughy part, right? And then you've got the nucleosa pulposa, which is like the jelly in the donut, right? So over time, as we age, we lose yin. Yin equals fluid, so things dry out. So things are less, what do you call it? Things bounce back less, right? Things become more brittle, right? And they lose its like sort of spongy buffering qualities. So over time, that there can be some deterioration in the annulus, and the jelly and the donut part, the doughy part of the donut, the jelly donut. And so it's susceptible to damage or deterioration from just wear and tear of like, you know, walking and lifting things and being active in gravity, right? So this is very common for anybody over the age of 40. So anyone over the age of 40 or someone maybe over the age of 35 who's had a very like labor intensive life, you're going to want to suspect that there's been some deterioration in the disc, which provides a buffer between the 2 vertebrae, which actually creates some space for those nerve roots to exit. And when that space is decreased, then there's pressure on the nerve roots that stimulates the nerve to fire and make the muscles contract, and that's what generates pain. Okay? All right. So any questions about any of that before we take a break? Okay, so let's break till 10, and we'll come back at 10 o'clock. By my watch, it's 9:46, so synchronized watches now. Can you see that?
Mm-hmm.
No?
Yes.
You got it? You guys got that okay? Okay. All right, so I want you to use that just as sort of like a backdrop and a context for what we're talking about. And then we're gonna go over the PowerPoints.
Time.
Yes.
Could you hold it up one more time? I think, oh yeah, that's just, oh, so crumbs. Oh, my system is hateful sometimes.
All right, I'll upload a picture of it.
That'd be
Okay.
Okay, I think I got it that time. Thank you.
Yeah, so basically you've got acute and chronic. And then within acute, you've got subacute. So basically acute is gonna either be with trauma or without trauma. But in a sense, even if it's like without like some kind of like, hey, I fell down and hurt myself. There is some kind of micro trauma happening, even if it's like, oh, I slept funny. There is some kind of like acute aggravation of the area, which is, and the two lower arrows means like very little, and the T stands for time. So this means very little time, short time, long time, right? Very, very little time, a little time, long time, more time. Does that make sense? Okay. So basically somebody's going to be in a car accident, or they hurt themselves at the gym, or they slept funny. There's going to be some kind of, to some degree, breakdown of tissues and substances. And by substances, I mean chi and blood, perhaps fluids. And then over time, again, this arrow here, they will have either blown it off and not treated it, right? Oh, it'll work itself out. Or they've injured themselves at the gym or CrossFit. I joke that I love People say, do you like CrossFit? I love CrossFit. CrossFit's why I bought my Prius in cash. So please keep doing the CrossFit, because you know I'm working up to the Beamer. So, right. So, or they've treated it poorly, like they just iced the bejesus out of it, and then over time, right, then they have like an increased susceptibility to external pathogenic factor, EPF invasion. Okay. And then with a chronic case, you've either got, right, so this is a chronic Zheng qi, that's your normal upright qi, Zhu, vacuity or deficiency, right? So you basically got a Shi or a Zhu condition, excess, deficient condition. Most chronic conditions start as a vacuity because either, and mostly because their system, their Zheng qi, their tissues are unable to sustain either the repetitive stress of what it is they're doing, right? Like I have a lot of patients that work for Giant Foods, you know, and like a lot of them work in the ice box, like in the cold, right? In refrigerated rooms, you know, or refrigerated trucks, you know, unloading trucks filled with like milk crates filled with gallons of milk and all kinds of other heavy stuff, where they're unloading pallets in a chilled part of the storage area. Excuse me. And so this repetitive stress combined with the external demands, right, of their yang qi, right, lead to a breakdown in the tissues and substances, right? And then over time, an increased susceptibility to even more external pathogenic factor. And that vicious cycle continues, right? Or people who work outside, or even just people who like do gardening and things like that, and you're exposed to the wind and you're sweating, right? A little bit of sweat, and you're bending over. So, you know, your neck is exposed, you know, the front and the back of the neck is exposed, maybe the top of the shoulders, right? The back of the head is all exposed, your face is exposed, right? But then there's also, you know, like normal activity, right? With a wind, cold, damp invasion, right? That's going to take a longer time to affect the patient, but that's compounded by increased aging, decreased quality of diet, and heightened emotions, heightened unprocessed emotions. And over time, that's going to lead to an increased susceptibility to invasion. Right? So there's a combination of a breakdown of substances and tissues and increased susceptibility to pathogenic factors, which sort of keeps the cycle going. So that's the overall larger context of what we're working with, okay? All right, so let me pull up this. Any questions about that before we start? Okay. Okay, I'm just going to go over this very briefly. And I'm going to minimize the your videos. So if you guys have any questions, just unmute and just interrupt me and ask. Let's see. Okay. All right. So the head and neck. Here's just a simple drawing of the major muscles that you'll find in the back, right? A lot of these are extensors, okay? Here's another little, like it's a little bit fuzzier, but here's another one from the side, right? That helps to see, you know, look at all the scalenes. You've got anterior, middle, and posterior scalenes, right? You've got that giant sternocleidomastoid muscle. You've got the levator scapula moving posteriorly and inferiorly. You've got the splenius muscle, right? The trap, right? The deltoids. By the way, anytime you're going to do E-stim, and we'll mention this later, don't do anything anterior of the SCM. All right, that can really mess with somebody. All right, so these are some of the basically the important head and neck muscles that we're going to be going over. You know, the different muscles and their different actions. You can use these as reference. Okay. Okay. So one of the ones that I see very often, especially when somebody's got like some kind of external pathogenic factor invasion, is treating gallbladder 20 and the motor point, which is a little bit south and lateral to gallbladder 20. And you want to needle it towards the opposite gallbladder 1. The other is the semispinalis capitis. So this is the motor point for this is found at bladder 10. More often than not, when I needle this point, I will have the patient not sitting up, but if they can be in, lying prone, face down in the face cradle, with their head like flexed just a little bit, with a little bit of like extra like bend, just a tiny bit, or straight. And you're going to needle this point towards the floor. Okay. So if they're sitting up straight, which you can do, but again, once you have them sitting up straight, gravity is pulling the head down, and it's going to subtly tighten even more an already tense and tight and probably overactive and shortened semispinalis capitis muscle. So if you can treat them lying either on their side or face down, it takes a lot of the pressure off of that muscle. And then what I like to do is then have them lay on their back and cup my hand under their head and under their occiput and do what's called like an occipital release, where you're just, it's almost like a half moon, if you learned that in zero balancing, where you're just kind of gripping your the pads of your fingers, all like 8 of your primary digits, and just bring some gentle tension and kind of hooking under the occiput and just gentle pulling towards you to kind of open that space up. You can even do that before needling this point too, which is really nice, and do it like in a slightly rocking motion. It's very nice. But this is a great motor point that releases a lot of tension. And you can needle this pretty deeply. You can go in like about 1 inch. The splenius cervicis, or cervicus, I'm not really sure how you pronounce it, but that's basically at a motor point called Bilao. And this is about 2 sun north and 1 sun lateral to do 14, all right? And you can also needle this pretty deeply. This is roughly in the area of like the intervertebral space just below C5, okay? And this is a phenomenal point. You can even use E-stim on these. This is so nice, so nice. And when I do E-stim, I'll talk a little bit more about that, but I don't put the positive, negative poles on either side of the vertebrae. What I'll do is and I'll show you this later, like I use a longer needle, which gives me more of the handle sticking up, and I bend them towards each other, and then I clip them together, and like the one above will be like at Bilao will be the positive, the black one, and then the negative, I guess. And then the one below, like maybe I'll do like around outside of like like Hwato Jiajis or motor points somewhere else, and I'll like hook them up below that. All right, so there's a bunch of Hwato Jiaji points found in the cervical vertebrae. I don't really do the Hwato Jiajis of C3. Generally, C4 is about as high as I like to go, and even then I'm not very commonly doing it. The space in there is really tight. There's usually so much muscle tension already. I generally prefer some myofascial massage or just some cupping and gua sha and manual massage to open that area up. And then maybe after a couple treatments of also distal points that help the circulation and perfuse that area with blood and qi, then I might go in with a Hwato Jiaji point. The Hwato Jiaji points are found about for the cervicals, about a half a sun, maybe to a 3/4 of a sun lateral to the governor vessel line in the intervertebral space, and then you're treating down into the facet joint. So actually here you can kind of see the facet joints. It looks like that part of the spine of the vertebrae that's coming out of the screen towards you that looks like it's been sawed in half, right? That's the facet joints, like just under them, where you see the, where each vertebrae would stack on top of the other. All right, so manual muscle tests of the neck extensors is really best done as a group. It's very hard to isolate them, right? So the patient is lying in a prone position with their head at the edge of the table. Their hands are palm down, either above their head or lying over across the end of the table, right? Make sure that the patient's chest remains on the table. You know, and basically what you're putting is your hand on the back of their head, sort of right around that occipital protuberance, maybe just below that. And then what you have to do is have the patient bring their head up, and then so after they've lifted their head up, they can tuck their chin just a little bit, and you're gonna push down, and they're gonna resist. And I've given you a YouTube link. Let's see if it works. And the video is unavailable. Yes, okay. Ta-da, okay. No worries. All right. So I have videos of me on my YouTube channel. So just very briefly, some important head and neck muscles, the SCM muscle, right? There's a motor point between small intestine 6 and large intestine 18. I generally needle somewhat obliquely anteriorly, from small intestine 16 towards large intestine 18 first. And then sometimes what I'll do is like, I'll really get a good grip of it in my fingers. Like I needle it, I activate it, and I take the needle out. And then I get a good grip on it with my fingers. I kind of pull it up a little bit, right? With the patient very gently turning their head to the side, not an extreme range of motion, just a little bit tilted, not as much as you would see this gentleman tilting his head, right? You wanna sort of make the muscle a little bit more prominent, but you don't wanna like activate it so much by an extreme lateral rotation, just a little bit turning to the left or right. I grab a hold of that muscle and then sort of like feeling the thickness of the muscle going about halfway while I'm still holding it, and I'll needle posteriorly stomach 9 to large intestine 18. So let me just show you what I mean by that. So I have the patient just turn, like in that picture, he's turning like way over. I'll just have them turn a little bit just to make the muscle pop up a little bit. And then I grab a hold of it. Right there. So I'll grab a hold of it and then needle like that into the muscle itself, right? So I've got a hold of it and I'm squeezing just a little bit, and then I needle just above my finger. So I grab just below it. So here's my laryngeal prominence right here. So here's stomach 9, here's large intestine 18, right? So I'd grab a hold just below that and then needle into it this way. It's, oh my God. People are like, oh. It is awesome. It is awesome.
So you're using one needle to hit all 3 points?
You can. I also needle it anteriorly from like small intestine 16.
Okay.
Yeah.
Did you mention already, is there vesiculation, or are you?
There will often be fasciculation, but not necessarily. But
Okay.
But more often than not, there is, especially if it's shortened and overactive. But I don't like go in there and jab at it until I get the fasciculation. Like you'll usually feel it. Like you'll feel the muscle jump a little bit, or you'll feel this like popping sensation, or you'll feel all of a sudden like the muscle like less tense, and you'll see the patient's shoulders drop a little bit, and you'll look at their face, and their face will generally indicate a little bit of relief. There might be a little bit of a radiating sensation.
Time?
Can you hear me?
Yes.
You sent us an emails with that, and that produced a video of you where the man was lying on the table and you manipulated his head. So that's in our email.
Okay. Yes, and it's also on my YouTube channel. Yeah.
Okay.
All right. Okay.
Time, can I ask a question before we move on?
Yes, of course.
Teresa. So when I'm trying to replicate at home what you did about, grabbing the muscle,
Yeah.
I forget what this artery is called, but I'm feeling a major, big pulse right up here.
Yeah, don't needle into that.
No, clearly, but are you below that or above that? I couldn't see.
I'd be superficial to that.
Okay. All right. Okay. Don't worry, I won't needle into anyone's.
I have no worries about you needling in anyone's jugular.
I have some worries about it.
Carotid.
Carotid, that's what it is.
Someone's arteries. Yeah.
Thank you.
All right.
All right.
So there are some YouTube videos on the SCM muscle test. Basically, they're just laying down on their back. They rotate their head away from the side being tested. They lift it up off the table. You can have them tuck their chin maybe an inch. Their patient's hands are above their head, like I surrender. And that helps you to avoid recruiting any of the other muscles. And then basically you're just applying pressure to the temporal area, like around where their temple is, and pressing down, like the line of drive is to, elongate the muscle in the anterior to posterior direction. So you're basically pushing straight down, and there's some videos of that. The scalenes, just very briefly, this is one of the things where like it's hard for me to like videotape, but just here's some basic ideas about how to needle into the anterior, medial, and posterior aspects of the scalenes. These are not a muscle that I needle into very often. Basically, this is the muscle I go to when everything else hasn't worked, which is pretty rare. A lot of times, if you take care of the SCM, if you take care of the levator scapula, if you take care of the rhomboids, a lot of the other stuff kind of falls into line. Also the pec minor, right? So if you're dealing with those like tissues in the front, a lot of the scalenes will just relax, especially when you deal with the pec minor, right? Which is around needling into like stomach 14, stomach 15, into the person about like 1/2 to 3/4, maybe even up to 1 inch into the muscle. And you can use e-stim on that. And a lot of times that will relax the scalenes. But we'll go over this later. I just wanted to introduce you to this, okay? So there's the scalene muscle test. These are common issues of the head and the neck. We'll go over torticollis, which is basically my neck hurts, which can also include neck strain from sleeping strange. There's actually a point called Lode Zen, an extra point on the hand I'll show you today, which actually means falling off the pillow, or some exercise or sports-related injuries, or the chronic arthritis or spondylosis or degenerative disc disease that might lead to TMJ. Okay. Obviously, these are the things they're going to be working with, which you know in the assessment document that I've given you, what makes them better or worse. You're going to assess Qi in blood, pathogenic factors. Is it acute or chronic? You know, you're going to be looking at the different channels. You're going to be applying manual muscle tests and orthopedic evaluations. Okay. All right, that's that. So let me, any questions about that? Okay, I'm just going to briefly go over what's called upper cross syndrome, and then we're going to go into some other things. Let's see, what's the time here? Okay, good. We're good on time. All right, so let's do this. All right, so there's something called upper cross syndrome. And basically, a lot of people come in with this, especially men. I don't know why, but a lot of people, I'm not sure why there's more men than women, but maybe we're just more uptight. I don't know. But you know, people will come in with kind of a forward head. So if you look at them from the side, their ear and the whole, like the auditory opening, is not over the area, that sort of spot between large intestine 15 and triple heater 14. You'll see it anterior. So it looks like their head is kind of pushed forward a little bit, right? And so this has an effect on, or is caused by, a problem with the muscles affecting the posture, okay? All of a sudden my cursor has disappeared. Okay. All right. So basically there's sort of like an X that occurs that you can draw where the center of that X is at the base of the nape of the neck. And you're looking from the side. So you can see here this gentleman has a forward leaning head. If you look at the opening of his auditory canal, like the center of his ear hole, that is forward to large intestine 15, triple heater 14. So what happens is the neck flexors become weak and inhibited, and the corresponding rhomboids and serratus anterior become inhibited. The pec minor especially, but sometimes the pec major as well, will become tight, and the upper traps and levator can become tight. And so anytime you see tight in a lot of the books or images, I want you to think shortened and overactive. And anytime you see weak, I want you to think lengthened and inhibited. What I'm talking about is the condition of the muscle fibers in the muscle. So the muscle fibers are kind of like a sine wave. And if the muscle fibers, if those sine waves are really, really short, like that would be like a high frequency wave, right? A great number of peaks and troughs through like a distance or a period of time, versus like a lengthened and inhibited muscle, which is very few, like a much like stretched out, more infrequent like peaks and valleys, right? So that's what you want to be thinking about. This is very common in a lot of weightlifters, powerlifters, bodybuilders, some gymnasts, right? And swimmers, but especially, what sport do you think might show a lot of this?
Rock climbing for sure.
You know, I hadn't thought about that. Yeah, rock climbing probably. Yeah, yeah, I can see that.
Guys in the gym that look like this.
Yeah, yeah. Especially because, you know, you're trying to like hug the wall, so, you know, the body goes where the head goes. So, you know, yeah, you're using a lot of your neck muscles in the upper back, your pecs, right? So the lower muscles and the flexors are going to become inhibited. But can you think of another type of athlete? It recently just ended. There was a big competition.
Oh, cycling.
Yes, bicycling.
Yeah.
You see this a lot in cyclists.
Hmm.
All right. So basically, the bladder and the kidney sinew meridians are going to be balancing the top portion, with the bladder sinew meridians dealing with the shortened and overactive cervical extensors and the suboccipital muscles. The kidney sinew meridians are going to be dealing with the deeper neck flexors. The lung and large intestine sinew meridians balance the bottom portion of the X, right? So there's the upper portion, bladder, kidney, bladder to the posterior, kidney to the anterior, right? And then large intestine, lung, again, large intestine, yang to the posterior, lung, anterior. So that's going to be dealing with the pec minor muscles and the pec major. Large intestine dealing more with the rhomboids and the traps, right? So just some pictures of the different muscles, right? There's the deep neck flexors, right? So basically, you're going to be doing manual muscle tests of the neck extensors, the pec minor, pec major, the rhomboids, the upper traps. You're going to palpate the area, you know, for any kind of trigger points, local Usher points, right? Here's a treatment. You're basically going to be treating the associated sinew meridians, which you know by doing the Jing Wells, and then including the gathering points, right? So the gathering point for large intestine, that's one of the 3-arm yang. That's the area between gallbladder 13 and stomach 8. Bladder is one of the 3-leg yang. So that's in the area between small intestine 18 and stomach 3, right? Lung, 3-arm yang, that's the area around gallbladder 22. 3-arm yin, excuse me. Kidney, 3-leg yin, that's going to be the area between CB2 and CB3. Right? And then I would highly recommend doing the G-clef points, possibly even the tonification points, which again alludes to, remember, the primary meridian treatments. One of the possible ways is to treat the tonification points. I generally treat the motor points of the shortened and overactive muscles first, because I'm doing them more as a sedating technique with intention. There's no real direction of flow, so I might be doing a little bit more lifting and thrusting with an emphasis on the lift. And I would be doing E-stim on these and doing E-stim for a longer period of time, maybe 10 to 15 minutes. And then I treat the motor points of the lengthened muscles next. That's my intention is generally on a more tonification transmission. So, you know, I might be doing a little bit of lifting and thrusting with the emphasis on the thrust, and a briefer period of E-stim, maybe about 5 minutes. It's nice to include the 4 gates when people who show up with this syndrome and are really stressed out, their mind's constantly going, they don't know how to let go. There's, you know, they're always planning. There's got this giant to-do list. They never relax, except for when they drink heavily. So this is your typical patient where they're drinking a venti coffee in the morning and a half a bottle of wine at night. And, you know, we laugh, but this is like half my patients. And then obviously, you know, Dumai is a great treatment for this. You can combine it with Renmai, which is also nice. You can also combine it with Chongmai, which again deals with the upper kidney points. I generally just do it with Dumai because just to balance that out, because people are so Governor Vesely in the world. These are like the type A, overambitious, hyperactive, you know, hyper intelligent. If somebody's like more on the depressed side, then you can maybe add or just do the CV. And obviously constitutional treatments to uplift the spirit. And I can't, it's kind of funny. Oh, there's my cursor.
Time.
Yes.
Are you seeing this as maybe a Zoom phenomena also? People that wouldn't normally be affected. But I'm like,
yeah.
I feel it in my body. I'm like,
yeah. Like you guys see me moving around a lot because like I'm constantly trying to like adjust my posture because I don't want to be stuck in like one posture too often. In fact, I would encourage some of you to stand up and move around during the lectures in your classes, because otherwise we're all, you know, like we're typing like this. You know what I mean? Like that's what we've become. Like we've become these, I don't know, like slot machine addicts.
but we're on computers instead. Like, you ever watch people gamble? Oh my God, it's like that. So anyway, yeah, so every now and then, like, you know, the antidote is to, like, you know, these neck extensor exercises, which we will go over later in the class. Also, if you want to maybe sell some gold jewelry and buy Matt Callison's book, you know, he's got a lot of extensive exercises. I'll give you some. But, you know, one of the biggest things that people can do are the shoulder rolls. So it's not just rolling your shoulders, right? It's bringing your comfortably as far forward as you can. And when you come back, like, you want to squeeze your scapula together, right? Like, squeeze them wing bones together, right? 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 Yeah. Not just rolling your shoulders, which is okay. But you want to squeeze them together, extend, and then squeeze together. And then roll as much as is comfortably in both directions. This is going to be a little bit easier for most people. This is a little bit harder for most people. I would actually have most people do sort of like towards the back, like up, back, down, right? I mean, I mean, is anyone like, does that, like, who can do that more than 10 times? I mean, it's, if you're really squeezing and retracting your scapula, it's exhausting. Because these muscles, again, a muscle is only as strong as its ability to relax. So if your muscles are really tense, they're going to be weak. Okay. So yeah, so this is the anti-zoom treatment, the upper cross syndrome, where the person's head is forward, right? The ear should be like right over this space between large intestine 15 and small intestine, right where the acromion, right, comes over. The ear hole, I don't know, I'm sure there's some anatomical term for your ear hole, but whatever it is, right, the auditory precipice, right, it should be like right over like the acromion. Okay.
Time looking at all these treatments you listed for us, you do the motor points first, and then you choose amongst these other things like four gates or first. I'm sorry?
Sinews first.
Sinews first.
Sinews first, right. But those were
primary meridians first.
Okay, I missed that. Okay, thank you.
Is that not on there?
It probably is, but I was looking.
Yeah, slide 8, last slide.
Okay, thank you.
Sinew meridians of the lung, large intestine, bladder, kidney, along with their sheath cleft points and or tonification points. Again, palpate, right? See which one is, you know, calling you or the patient. Then I would treat the motor points of the overactive muscles first, and then the motor points of the lengthened muscles second. That's usually like, and then I might add some constitutional points, and that's basically it.
Okay. Okay,
you may not even need to do the motor points, but you can palpate them, and you know there's a couple way of dealing with the whoops. Okay. All right. Can you guys see me? Okay.
Yes.
Okay.
Yes.
So there's a couple way of dealing with. I'll bring it next time. I forgot to bring it home with me, but there's a couple way of activating the motor points. One is simply you just needle into it. You give it a little stimulation, just a little bit of stimulation. You might do a little gentle lifting and thrusting, and then leave it in for just like a couple minutes to up to maybe 5-10 minutes. You don't need to leave these in for a long period of time. That's one simple way. The other way is to get like one of these pointer pluses. It's like a long sort of like pen with a metal tip, and it provides a small electrical stimulation, and you just kind of zap it a couple times. All right. And sometimes the needle or the muscle will vesiculate. Or you can get eStim and you can hook it up to maybe another local point or another motor point, or you can put more than one needle in a motor point and hook both of the leads up to those.
where black is always like the anterior, more anterior of the two, right? So that's a way of like stimulating the motor points. Okay. All right. Any questions about that? This is a really nice treatment to do where like somebody comes in, they've got a lot of neck stuff going on, and you have them stand sideways and you evaluate their posture and you see that their head's pretty forward, right? Or slumped. This is a great treatment to do after AE or possession. Maybe even before Akabanis, where you're giving the patient like a lot of relief. And then also, you know, giving them some exercises where like the shoulder rolls or some other exercises that I'll give you towards the end, or I'll post them later if we don't have time to go over them today. That gives the patient like quite a bit of relief and really establishes a nice sense of trust in the patient. And, you know, they feel, I mean, it can really change their whole mood. It's really nice. And if they're like super stressed, that's when you can like throw in the 4 gates. All right. Also with the 4 gates, they sometimes add pericardium 6. So it's like the 6 gates, I guess. All right. Okay. Any questions about that? Forward head, give it a shot, sinew meridians, lung, large intestine, bladder, kidney. Maybe do some, before you've, you know, after you've treated the sinews, you take them out. You can leave them in for about a half an hour, up to a half an hour. If it's very severe and acute, if they're having like an acute situation, you can bleed the Jing wells. Otherwise, you can leave it in for a little bit. And then I take the needles out and then do the manual muscle tests. You can also do the manual muscle tests first, but honestly, the sinew meridian treatment, law of least action, that might have covered it. So you may not have to do much else. But again, they're always going to fall back into their old postures without exercises. Okay. All right. So let's look at, I don't think I need to go through the aspect of the notes that go over like assessment basics. You know, that's been covered before in previous classes. Here's like sort of like your checklist of how you go through and assess things, right? Do any of you need me to review that with you? Okay. All right. And again, it's a simple checklist that you can use or not use. You know, for me, it's a nice way of kind of like creating sort of a ritual, right? Any kind of routine done in a sacred way becomes a ritual. And so it's a nice way also for me to like organize my work in the treatment room. Okay, so you've basically got like 2 basic things going on. You've got acute or chronic. And within acute, you've got some kind of impact, injury, traumatic injury, or you've got some kind of acute situation that's not necessarily trauma, macro trauma related. Maybe they come in, they say, you know, I slept funny and I just woke up, but I got this like crick in my neck and it's just really sore, or, you know, like had a lot going on at work and it's been really busy and I'm stressed out. And like all of a sudden, you know, like I woke up today and like my neck is like really just tight and achy, right? Or suddenly, you know, again, this might be part of a chronic problem, but like anything that like that generally suddenly gets their patient's attention, okay? And that's either going to be with trauma or without trauma. And it's not going to be a mystery. Someone will say, you know, I was in a car accident, or I was working out and I was doing like lat pulls downs, or I was doing like maybe some yoga move, right? They were doing like downward dog, and then they worked their way into like the cobra pose. And when they came back up, oh, like I tweaked my neck, right? Or somebody was like out, like, you know, like, you know, there's going to be like something pretty obvious, right? You know, it's not going to be like, I was gardening yesterday and it was like kind of damp and I was sweaty and then it got cool suddenly. And then, you know, I woke up today with like a crick in my neck, right? So there's going to be trauma and without trauma. With trauma, there's generally going to be a lot more heat. And there's going to be generally more blood stagnation. And there's generally going to be, where there's blood stagnation, where there's tissue damage, there's always blood stagnation and heat. Where there's tissue damage, there's always blood stagnation and heat. So in case you didn't get that, where there's tissue damage, there's blood stasis and heat. All right.
Are you on page, I'm lost as to where we are in your notes.
Sorry, page 4, acute conditions.
Okay, thank you. Got it.
So sudden impact trauma, a sprain, a sudden strain, there's a resultant tissue damage, which may or may not be palpable by you or the patient. It may show up as a muscle knot. It might show up as swelling. It might actually show up as inflammation or a bruise, right? It's going to affect their postural muscles. It may affect their posture itself, right? And there's going to be some kind of pain, and there's probably going to be, guaranteed like some kind of pain and or impaired function. It means like impaired function means I can't move a certain way, right? So these are almost always going to entail local stagnation of qi and blood at the muscle level. There's always going to be some degree of heat, and there's always going to be some degree of blood stasis and heat toxins, sort of like, what's that say? Proportional to the amount of tissue damage. Okay, so when I say toxins, there's a couple different types of toxins. One is basically a toxin is anything that shouldn't be there that's destructive. So one is heat. Heat is organically degenerative, right? That's why you see like some old people that have had like hot, damp B rheumatism, their knuckles are all sort of like misshapen, right? So this is where you're going to be clearing heat, right? You're going to be moving blood stasis. These are going to be like your primary treatment principles, right? So basically you go through the assessment process like I've showed you, what makes it better or worse, right? You're going to listen to their report of symptoms, right? You're going to check for signs and symptoms of external pathogenic factors or external pathogenic factor like signs and symptoms, right? Which I don't think we have to go over, right? Maybe it moves around or it comes and goes in different times, but it's always there, but sometimes it's worse and sometimes it's a little bit better, right? That's more wind, right? You know about cold, you know about damp, fixed, heavy, right? Different ones. You're gonna feel their pulse and tongue. Pulse and tongue are going to give you more of a sense of what's going on systemically with their zheng qi, right? Are they qi deficient, but now they've got this Shi condition, which has left them susceptible to like some kind of injury, because they've been weak, or the wei qi is weak and they're susceptible to an external pathogenic factor invasion, right? You're going to visually inspect the area. You're going to palpate the area. You're going to assess the different meridians, right? You're going to go through the primary meridian movements, sinew meridian movements. I've added benefit of added on the bottom of page 4, I've given you some of the primary and secondary muscles associated with each of the sinew meridians. Why would I give you that? Because you're going to have access to some of the manual muscle tests. So if a sinew meridian tests positive for involvement, then I then go and I say, okay, these muscles may be involved in this problem. Now I'm going to go do manual muscle tests and palpate along these muscles to see how they are. Does that make sense? It gives you like a sense of like, how do I like focus my treatment? Does this make sense? Right? So you do your primary meridians assessments, you do your sinew meridian assessment. Based on the sinew meridian assessment, it may imply the involvement of certain specific muscles, which then you can do a manual muscle test on. You can palpate, right? I've also given you the added little bit on page 4 under letter G, under assessment, where it says number 2, sinew, where it says neck rotation, Xiaoyang, right? Neck extension and flexion, Taiyang. Neck bearing weight, like I'm just, right? These are your foraminal compression tests, or just holding your head up for a period of time. That's Yang Ming. These may imply the involvement of certain external pathogenic factors. It's not a given. It's not always 100%, but it's something to keep in mind where if somebody has neck rotation problems, it may imply the involvement of wind damp, so you can choose points that are good for dispelling wind and resolving damp. And your primary dispelling wind, resolving damp type of treatment would be gua sha for the wind and needle with moxa on the top of the needle for damp. That's not in your notes. So one of the great ways to deal with wind is to cup and then gua sha. And then a great way to deal with damp is to needle with moxa on the needle. Okay. There's also the circular needle technique for wind, right? So you can go in there and like gallbladder 20 and like whirl the needle around and then pull it out, kind of like stirring up a tornado to draw the wind out. You go in, small circles, getting bigger as I'm pulling the needle further out and then out. And in this case, the way I'm doing it now would be a 6-inch needle, but you can just start off with 1 or 1.5 inch. I'm just kidding. I only use 6-inch for hips. All right, so neck extension, flexion, that implies Taiyang, right? That implies wind cold. So I'm going to be doing treatments that help with the wind and the cold. So cupping is really great for cold and blood stasis. Gua sha is great for wind heat, right? Use of moxa, direct moxa for cold, fantastic, right? Neck bearing weight, it just hurts with my head sitting there. That implies wind heat. Again, gua sha, awesome for that, right? Not so much moxa. Cupping, kind of, sort of, not so great. All right, does that make sense? So I'm just giving you like another bit of information to fold in to help you consolidate like your treatment plan, okay? We'll go over that in terms of examples, right? Because we'll actually run through an example today. Yeah, question.
Quick question on if someone is having wind symptoms in their head, like facial muscle spasms, do you gua sha that area too, or cup that, or how do you
can do some gentle silicone cupping on the face. I'm not a big fan of gua sha on the face.
No, because it's too rough?
Well, I'm just not well versed in it. I mean, Michelle Gellis probably does it.
Mm-hmm.
Plus, I mean, when done successfully, you're bringing a bruise to the area. And I don't know how many people want to walk around with like a gua sha bruise on their face. I mean,
good point.
Unless you're like Mike Tyson or something, you know what I mean? Like, if you don't know who Mike Tyson is, he's a boxer. He's got this like giant tattoo on the left side of his face.
That's scary.
But most of us probably not so into having like gua sha bruise on the face. And also just like the blood vessels on the face are really easy to break.
Mm-hmm.
And
okay.
I'm not, and you know, that can lead to like more permanent facial disfigurements. Okay. So I know Michelle and other, facial rejuvenation, like face needs rejuvenating. I don't know, but whatever. It's like, whatever. If people are into it, like go with God. But like, she does like some gentle cupping on the face with these little cups that have like the blue silicone ball. I just be really careful as a beginner. I wouldn't do anything like that unless I had specific training from an expert like Michelle Gellis or some of the other facial rejuvenation people.
Okay. All right. Thank
you.
You
can needle locally without messing them up. You can needle distally without messing up their face.
Okay. All right. Thank you.
Yeah. All right. So with acute issues, generally, especially where there's trauma, clearing heat, moving or invigorating blood locally and systemically, which can be done in a couple of different ways. So clearing heat, any kind of like lift and thrust where the emphasis is on the lift, or relatively superficial needling, or middle or distal points, or maybe even some local points if they're around, are good for like drawing heat out of the system. So a lot of the what do you call it? The window of the sky points are really good for clearing wind and heat. Gua sha is good for clearing wind and heat. You know, some of the other points go up like triple heater 15, large intestine 15, large intestine 11, large intestine 20, stomach 2 and 3, stomach 8. These are really good at clearing heat. Invigorating blood in the local level, the sinew meridians and bleeding points. Bleeding points are absolutely awesome for moving blood. There's a couple ways you can deal with this. One is you can do your cupping and your gua sha or not, and then you can start off with your either second or first doing the sinew meridian treatment. If it's pretty severe, I would bleed the Jing well. So you know, like let's say you're doing large intestine 1, you pump the point, right? Pressing on the nail and the pad, pump it up a little bit, like 10 times. You lance it, that point, you squeeze the blood out, squeeze, wipe, squeeze, wipe, squeeze, wipe, or just keep squeezing, wipe a little bit, squeeze, 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 wipe, right? You're getting blood out. That does actually, remember, like in a viscous solution, like even water or any other kind of viscous solution, there's a tension, there's a cellular tension and a molecular tension between all of the molecules in the cells, especially the molecules in any kind of fluid. So once you start something flowing, it's like they're all like, these molecules are like links in a chain, and you start, like it's like dropping an anchor, you know, like or like setting off a kite. You know, you're escaping this external pathogenic factor via the Jing well point, and that pulls the blood through that channel. You're not emptying the channel. I mean, you're only getting like 10, 12 drops of, but all of those molecules adhere to one another. So when you start that movement, you invigorate the flow of movement all through that trajectory. So it's almost like you're letting a kite go, and that string, you know, is like all of the blood like on that string is like being like kind of pulled along. Does that make sense? Am I making any sense with that?
Yes.
Okay. All right. So, right, just like if you're pouring water slowly out of a cup, you know how it like kind of grips and it just pulls all the other water like along the edge of that cup, right? Because there's molecular adhesion. So that also helps to also expel pathogenic factors. It invigorates the blood, it clears heat, it clears cold, it clears wind. It also relaxes the fascia. So, and that also relieves the pressure, which relieves pain. So just the Jing well points and the sinew meridian treatments help treatment strategies A through D, which is on top of page 5. Right? So right there, you can do so much with the Jing wells along with the gathering points. And then any kind of trajectory points like the G-clef points, okay? You can also, if it's like super tight, if that Jing wells and the sinew meridians have gotten you like a little bit, before you even do like C, tonification and Ashi points along the primary channels, you can go back and find some muscle knots and maybe needle like into the Ashi points, or even before that, find some muscle knots or places where it's very asher, and you can put a cup on there, get some suction going, just gentle suction to get some blood drawn into that area. Then you go back and I lancet it 1 to 3 times. If I've got a pretty hardy patient, 3 lancets right in a triangle. If they're very sensitive, 1 lancet, right? But generally, I'd like odd numbers because I feel it's a yang treatment, so I'm doing yang numbers. But you don't have to be so ADD about it. And then I put the cup back on, and then I draw some of the, that's like wet cupping. Then I draw some of the blood out, right? Make sure you clean the area with, you know, some of the betadine or that brown stuff that whose name I can never remember it. What is it called? It cleans the area, like before you do like a needle injection, they put some of this on it. Huh?
Hibiclens?
Hibiclens is okay. It's brown.
Iodine?
It,
I mean, it's just the betadine is the brown.
yes, betadine. Yeah. Betadine, Hibiclens. Did I say betadine?
You did.
Oh, okay, great. Yeah.
Yeah.
So the brown stuff, clean that off, put on a glove, right? Just like Michael, one glove is all you need. Cup it, get some blood up, lance it, put the cup back on, draw a little blood out, have your tissues or your paper towel, right? And your gloved hand ready, right? Put the paper towel in your gloved hand. Like I see this all the time. People glove their hand and then they hold the paper towel in the other hand and they go and wipe it with that hand. That's useless, right? Make sure you get the glove in your dominant hand, right? Take the cup off, wipe that out. Maybe up to like a teaspoon of blood is plenty. Okay. If they're very chi deficient, quarter teaspoon, eighth of a teaspoon, right? A few drops. That can help invigorate the chi. It activates the Wei Qi. It moves blood, moves stasis. Very nice. And, you know, more often than not, the patient's going to be like, wow, that's so much better. Oh my God, that's great. You're a miracle worker, right?
Huh.
If there's still like, you know, if I get up to like 50% better, this is why you want to assess on a scale of 1 to 10. I know it's a pain, you know, to like go through these like stupid, you know, like analog scales, like some patients like hate it. But, you know, if 10 is hit by bus, 0 is no problem. You know, how would you rate it in the beginning? Like, oh yeah. And so you look at their range of motion, right? You note down like sort of degrees, you know, 0 to owl, right? And then, you know, you also want to measure the pain beforehand. And then afterwards, you know, have them move around again. Is there improved range of motion? If the pain has been reduced by 50%, that's really, really, really good. I want to calibrate your expectations here. That is really, really good. Okay? That's outstanding. You're always going to have some metal CF or some like spleen earth CF. It's like, well, I still feel it. So, you know, you need to, you know, tend accordingly. I know this is going to take some time, but this will really help. Okay. Or some metal CF's like, yes, some improvement. I don't know why, but I naturally put a British accent on metal CFs. So that's pretty good. And then if you want to go further, like you can ask the patient, okay, well, you know, like in my experience, like I don't want to do too much at once, but if you're really, really like not going to be satisfied until we do a little bit more, then okay, there's another level we can take it. And then you try the primary meridian treatments, which is your tonification points, or if they don't work, sedation points. I do tonification first because that's quick, right? In and out, or even in for like 5 minutes. Then you retest with the needles in. If that's not helpful, you take the needles out, you treat the sedation points, leave them in for 15 to 30 minutes. While the sedation points are in, you can also treat some Usher points, right? Or maybe palpate along the channel. Maybe there's some like naughty spots, right? They've been very naughty. And so you can palpate along there and needle into them as Usher points, or maybe do like another G-clef point or low junction point, right? You can even bleed the low junction point, right? So those are things you can do while the tonification points are in. You can also then go to the next step, which is E, not D, like because the patient's probably lying down. I mentioned D after C, but for now, like skip from C to E. And this is a time when the patient's like lying supine, they're laying on their back. You can do some distal points, like balance method points, right? So very briefly, the shoestring points relate to about where C1, C2 is, right? So large intestine 3, triple heater 3, small intestine 3, done with a fist, loose fist. So not like Dances with Wolves. This is patient lies with loose fist, not stands with fist, right? Right. So you can also do Lot Zen, which is a point sort of just to the side of it's the late neighbor of Zongbai or triple heater 3. You can needle into there. You can also needle into there. You can also do the San Sha points, right? Needling in this way, like the Wolverine points, okay? But usually like just a couple of these is good if they feel it like right up at the occiput. If it's closer down to like C7, T1, around Du14, that's gonna be your wrist crease, okay? Obviously, these are gonna be the space between C1, C2, C7, T1, and areas in between. So you can palpate and where it's comfortable to needle, which is best, I think, where in the medial points, which is like along small intestine, to some degree, a little bit of triple heater and large intestine. These are gonna be the areas that are gonna be more comfortable to needle for the patient. And then once those are in, I have them move their head and neck around, right? And you can stimulate these points, like small intestine 3, small intestine 3 1/3, small intestine 3 2/3, or 3/4, right? And then 4. You can manipulate these needles while the patient's like moving around for like a couple of minutes, okay? And that, or down on the kidney channel, like between kidney 3 and 5 and 7, right? Around the bladder 60 area. Gallbladder 40 to 39 is really good for also neck points. Just have them move around a little bit, okay? Right, and that generally is plenty for a treatment, like one treatment. If the patient is still like super tight, I might add a few of these Master Dong extra points, which I've described here. You can do 20 just to help them chill out and relax. You can do Lot Zen, which is sort of like triple heater 3, but one digit over. The San Cha San points, which are like the Wolverine points, which you like needling, right? So they're like the Ba Feng points, right? So you've got knuckle, apex, right under that tendon there, needling parallel, okay? You can use 1 inch or 1.5 inch needle. If you're nervous about doing it for the first time, use a silicone-coated needle, right? Use like a 36 gauge. I wouldn't do 38. 38's a little hard to manipulate, but 36 gauge, DBC Spring 10, right? Or a Sarin. Feel for the groove, right? I've included a video on doing the San Cha on the canvas. There's also some other points, Master Dong points. So if you have the patient in you're able to have them lying prone, or they're sitting down and not laying on their back, there's these 3 points along the Achilles tendon. So here's like the heel of the hand, the heel of the foot, right? So here's my Achilles tendon running this way, like my knee would be up here. 3.5 sun up into the Achilles tendon, then 2 more sun up proximal, and then 2 more sun proximal. Right into the center of the Achilles tendon. I squeeze the Achilles tendon and I needle right into there. And people might be like, oh my God, that's gonna be so painful. People don't even hardly feel it. They feel like a little bit of pressure. There's not a lot of nerves in the Achilles tendon. Most people, like, they feel the tap and go in, they feel a little pressure, they don't feel much else. So that's especially good, obviously, for when the pain is right along the center of the back, like along the cervicals of the neck, right? So that's something you can also do later after these other points. Wow, it's still really, gosh, it really hurts a lot right in the center. So after you've done all the other points with them lying supine, you can have them lie prone or sitting if lying prone is uncomfortable for them. And then just get behind them, or, you know, if they're laying down on top, put a little pillow on the feet to relax the Achilles so it's not strained, right? So there's a little bit of a like looseness of the Achilles tendon. And you can needle, you squeeze the tendon, tap the needle in, and then while you're squeezing the tendon, just slide the needle in there. You can use an inch, inch and a half, right in the center of the Achilles tendon. 3.5 sun from the bottom of the heel, sort of like right at the beginning of like the bend at the top of the heel. And then 2 sun, and then 2 sun. Honestly, I rarely do more than 2 of them. I'll do 7701, which is 3.5 sun up, and 7702, and usually that's plenty. And that's quite a bit, right? And that's like a good single first treatment, right? The next time they come in, test the sinews, test the primaries. If the sinews are still an issue, you can treat them again. If the primaries are still an issue, treat them again. If there's still a lot of tension and like hardness, that's when I go to like small intestine 13, 14, and 15. And then I'll add either 12 or 11 and do E-stim on those, right? So I've got the black head of the E-stim on small intestine 13 or 15, the most superior. Then the next one on, and then the red one on small intestine 14, then a black one on small intestine 12, and then the red one on small intestine 11, right? So the more superior or anterior is the black lead, and then the more inferior or posterior is the red lead. Okay? And then I'll leave that on for like 5-10 minutes. So I try and do what I can without the E-stim first. If the patient's like really locked up and it hurts to needle them, I'll start with the cupping and the gua sha, try and loosen up things, and then I'll go to the E-stim on small intestine 13, 14, and 15 to deal with the levator scapula muscles. And that can really help to loosen things up. If things are like really super locked up, that's when I might do that. Does that make sense? All right, so let's take a break till like 20 after, and then we'll come back and we'll do the rest of acute without trauma and the chronic. So there's 2 types of trauma. One is going to be trauma to the soft tissue, which is largely what we just covered, right? The treatments that we've gone over, that's largely to the soft tissue, that is the muscle tissue. Some patients are going to come in with having had neck trauma or head and neck trauma where the discs are involved and there's some kind of what's called radiculopathy. Radiculopathy. So in what we just covered, the patient will not be experiencing any kind of radiating pain either from their neck down into the shoulders or like up into the head or down into the traps or maybe even down into the arm, even as much as the hand, right? That's what we just covered is basically soft tissue damage to the muscles, right? Maybe a little bit of like tendons, neck tendon sprain, right? But the next bit I want to go over briefly is when there's been damage that is now affecting the discs or the facet joints. Again, the facet joints are like the spaces where the little headers and footers of the vertebrae stack on top of each other. And each of where they like rest, the top one rests onto the bottom one, there's actually like a little joint space around that. And so when you're needling into the Huatou Jiaji points, you're actually needling into the facet joints. So someone will come in, they've got some kind of pain, there will almost always be some kind of weakness and stiffness attending this, and they will have some kind of either a disc bulge, which means the jelly donut has been expanded in one direction where the jelly has been pushed usually through some kind of forceful movement, or they were like in a car accident and they were suddenly stopped a certain movement, right? And it put like a strain. Usually it comes from like lifting something heavy, or some kind of strain from an impact, like falling off a bike, or being in a car accident, right? Where all of a sudden the jelly in the donut is pushing up against the donut part, right? The nucleus pulposus is pushing up against the annulus, and it's bulging that jelly donut out in a way that pushes against the nerve root that's emerging from the spine. And that pushing on that nerve root stimulates the muscle, stimulates the nerve to fire, which then contracts a lot of the muscles, and that's what generates a lot of that pain. So they might experience pain, a radiating pain, or a numbness, or a tingling. So radiculopathy is going to be a numbness, a tingling, with pain, with pain, with pain,
with pain,
with pain, with pain. You may have a now that means like, or the disc is not just bulging and pushing up against that nerve root, stimulating a pain sensation that's radiating. There may be an actual rupture or herniation where the donut has torn and some of that jelly has escaped and is pushing. It's a very thick viscous fluid and it's pushing up against that nerve root, which is also creating some pain. Now these can heal over time. Depending on the age of the person, so it will depend on the degree of like the higher the age, the slower and less healing will occur. 21-year-old healing's pretty quick and relatively thorough. So if there's just a facet joint problem where there's like a strain or a sprain on that joint, you may get what's called paresthesia, which is like a spreading numbness or tingling sensation, which may or may not follow a trajectory, like a nerve or a sinew meridian, but will not be pain. It will not be pain, more often than not. If there is a facet joint problem that's also creating pain, it means that the damage has now affected the nerve root to the extent where there's pain. But more often than not, the facet joint is just paresthesia, which is like radiculopathy without the pain. But radiculopathy is going to be like a radiating pain sensation that may or may not include numbness and tingling. And that's almost always nerve root damage, disc, because of a disc involvement. And so then you're going to be doing all the same stuff before. If you're going to cup really gently. I would use like just mild suction, gentle suction. Gua sha gently, right? Because there's a lot of tissue damage in that area. You don't want to re-aggravate it. Sinew meridian treatments are outstanding. The tonification and Ashi points are pretty good. The E-stim on small intestine 13, 14, 15 can be quite good. What you're going to want to also include, though, is the Huatou Jiaji points. So just lateral to the Umai, right, about 1/2 to 3/4 sun lateral in the intervertebral space. These are listed in Deadman, right? And so I'll see if I can make a video of this. It just hasn't really worked out. But I'll see if I can do this where like you'll have the patient supine, prone. You have the patient prone, they're laying face down, and you're going like perpendicular to the skin with 1 inch or 1.5 inch needle, and you're going in about like, again, the intervertebral space, about 1/2 to 3/4 sun, lateral to the governor vessel line, straight in, very slowly, very gently. They're going to go through some area of tension where the patient's going to jump a little bit. It might even be uncomfortable. That discomfort should only last a second or two and then should dissipate. If you've needled into it and the patient's like, God, man, that pain is just not going away, take the needle out. Slowly. Anytime you use a Hwato Jiaji point, I gently put my fingers on either side of the needle, very gentle pressure, very gentle, and slowly withdraw the needle. Because those muscles are very excited and they can grab, which can be a little bit uncomfortable for the patient, but it's not alarming. But they may feel it a little bit, like it may go, ah, oh, okay, now it's gone. That's okay. Like, don't get freaked out by that. Like, and if you hit bone, that's good. You're hitting the facet joint. You can tap the facet joint a couple times, 2 or 3 times, right? And then you've got one on either side. And what I would do is, and you can maybe even get the report from the doctor where they say herniation between C5 and C6. So then what you want to do is you want to do those Hwato Jiaji points first between C5 and C6. And again, if it's too painful for the needle to go all the way down to the facet joint, just go in to the point where it's like comfortable. Like if it's, oh, okay, that's too far, that's not going away. Just back it off a few millimeters. And if it's comfortable, leave them there. That's fine. You don't always have to go down to the facet joint. Then I do the one above. Then I do the ones below. So I generally do them in sets of 6. The 2 on either side, or where the problem is, and then 1 above, right? 2 on either the intervertebral space above, 2 in the intervertebral space below. And then with these, so let's say the patient is laying this way and here's their head, and I've got the Hwato Jiaji points in, right? So here now you're like I'm like, let's say I'm like this, right? And so like close to the camera is the head, or maybe out here is the head and here's the feet. So I've got 2 needles in, right? Either side. And what you can do is you take like maybe a 2-inch or an 1.5 inch needle, use those. And then what I do is I bend, obviously this isn't going to angle out, right? So I'm going to bend these together, and I'm going to clamp one alligator clip of the E-stem there, and then the next one down, I'm going to clamp the red one there. So the higher one gets the black one, the lower one gets the red. So you're not doing black and red across the spinal column. I've heard that can muck somebody up. I don't know enough about it, but I've just heard like, don't do that. Okay. Like don't cross the GV line with your black and red alligator clip E-stem connectors. Does that make sense? So I've got like above it, or maybe in the area, like at the level, and then I bend them together and I clamp maybe the black one there for one channel, and then I've got one below that, I bend them together, clamp the red one there, right? And those are 2 heads of the same cord going into one channel on my E-stem device. Does that make sense? So I'm not doing black and red, I'm doing black and red. Okay? You don't have to do E-stem. You can hit it with the pointer plus, or you can just leave it. And then with that, I would then palpate down that dermatome, which I've included in your list of documents I think in the beginning section of the modules. Like you can look for like dermatomes, like, okay, so the nerve root coming out of here innervates this area of like the arm. So if they have like numbness and tingling down the arm, if you look up exactly like where they feel that corresponds to a certain nerve root, right? So here's C8, which means the nerve root below C7. This is usually like C7 and C6 and then C5, right? Does that make sense? And then what you can do is while they're supine, while they're prone and you've got those needles in, the Hwato Jiaji points with or without E-stem, you can also do the small intestine 13, 14, 15 points. And then you can also do like a few, just maybe shallow or into the muscle level, like points along the trajectory of where they feel the discomfort, which might be Ashi points, or they might be like G-clef points, or maybe even low junction points. Does that make sense?
Do you do this with people that both have pain and do not have pain? Is there a difference of
If
this procedure?
It's with pain that's from some kind of problem affecting the nerve root, where either the disc over time has deteriorated, and then they do some activity that's fairly normal, but it's too much for them to bear because the discs and muscles are so weak that it damages the nerve root, and then there's radiating pain, or some kind of traumatic impact injury that has damaged the disc, which is then aggravated the nerve root, which is then resulting in radiating pain. Right?
So this whole procedure you've just told us is for people that have radiating pain. Is that correct?
Yes.
Okay, thank you.
Yeah. Like at the very beginning, I said, like, this is for people with radiculopathy. This is a radiating pain that may or may not also have numbness or tingling. And that is a sign that this is a damage to either the disc or the nerve root.
Right.
Hey, Tom.
Yeah.
Is the term radiculopathy in our notes somewhere? I'm searching for it because I'm not clear where we are again. I'm lost again.
It may not be. It is going to be in a PowerPoint when we cover the back.
Okay.
But basically, you can just look it up. I mean, it's like, for our purposes, it's radiating pain.
Okay. Thank you.
That may or may not have with it numbness and tingling.
Okay.
So this is the time when I generally use more local points. If it's just soft tissue damage, I do distal points first. Like I do cupping and gua sha, then I do distal points. And then if needed, I go back and maybe do those 3 small intestine points for the levator. I might do ashi points, right? But distal points are generally going to be like my big thing. Sinew treatments, primary meridian treatments, extra or empirical points like balance method or master dung, right? And then I might also do motor points. If needed, then I'll go to the local area, do ashi or motor points. I'm not a big trigger point person. You can also include auricular points, or you can include ear seeds or press tacks, or the ASP needles, the ASP needles, right? You guys know what they are? They're using like battlefield acupuncture. You just pop them in there. They look like jewelry, right? So, this is the area for the neck, right along in, let's see, right in like this area.
In the bottom.
Cervical spine here. Then there's like a neck point here. Then there's like a neck point up there. I don't know why there's a neck point up here, but there is. But you can look that up in Terry Olson's book, or just go online. ASP needles, like if somebody's like got a lot of stiffness and a lot of pain that like, you've done a couple treatments and it doesn't seem to last more than like a day, like then I'll use the ASP needles or the press tacks. Or if that weirds you out, or if the patient's weirded out by that, just ear seeds, and then they can massage that ear seed, like the Vicarious seeds, okay? And then, some spirit or constitutional points. I generally don't do more than like 6 to 8 points, right? In a treatment. The exception is when they're coming in with radiculopathy from damage to a disc or a nerve root, where I might do like 10, 12 points, right? Where I'm doing the local Huato Jiaji points. I'm doing these myotomal motor points, which are like points along the trajectory of the pain, as well as the sinew treatments. And then I may or may not add like a couple of empirical extra points, or some balance method points. I have to say, when there's damage to the nerve root or the disc, the balance method is moderately effective. What I found to be most effective are the Huato Jiajis the sinew meridian treatment, and the empirical / extra points like Master Dung points that I've listed for you. And then after that, if there's still a lot of tension in the neck that extends down into like the torso, then I might do the small intestine 15, 14, and 13. But that's generally like for radiculopathy, that's been like my go-to thing, the Hua-Tuo Jiao-Ji points. Now, if they're too intense for the patient and they can't take it and they still hurt, like don't force the issue, just take them out, right? Or needle them more shallowly. There's no rule that says they have to go like way deep in there. I needle as deeply as I possibly can down to the facet joint if possible, and I peck at the facet joint, and then I'll put like E-stim on it, and then I'll do the sinew meridian treatments, and then I'll do Osher points like along the trajectory, or other points along the trajectory like low points or G-clef points, and then I'll throw in some empirical or extra points. And that's usually pretty good. If that's not enough, I might do a couple of motor points in that treatment, but that's plenty. That's plenty. And if you want to end on like CF points, that's great too. While the patient is prone, it gives you easy access to do 20, which is very relaxing. So that's helpful. Okay. So that's sort of like my radiculopathy treatments, right? If they can take it, the Hua-Tuo Jiao-Ji points, sinew meridian, empirical extra points that are distal, that help with the neck, and then maybe some motor points, and then a couple of spirit points, 1 or 2 spirit points or constitutional points. Does that make sense? All right.
Yes.
Okay. So that's going to be one of the things that you see a lot of is these cervical disc problems that have either deteriorated over time and then somebody did something like, and now all of a sudden they've got like radiating pain, or they've had some kind of traumatic injury leading to radiculopathy and damage to the disc. That's something that you'll see pretty common. What's also very common is like sudden onset with no trauma, right? And that would be like they wake up, they kind of like they've slept funny, or they've just been doing like a lot of gardening or like a lot of repetitive stress stuff going on, or chronic issues that have been with like a gradual onset, especially people who are older or people who have or younger people who have extremely physical jobs, or older people who've had physical jobs their whole life. You know, like I think about my grandfather who worked for Baltimore Gas and Electric Company for 45 years, you know, like he was doing very, very, very physical work outside around extremely high voltage. So, you know, wind, rain, snow, 100 degrees out, tough. You're working, right? So these would be things where either the external pathogenic factor is so strong that it's overcome our normally strong Wei Qi and Zheng Qi, or our Wei Qi and Zheng Qi has become so weakened and deteriorated over time, repetitive stress, poor diet, intense emotions, unresolved, then like a fairly normal external pathogenic, normal strength pathogenic factor comes in and overwhelms that. Okay, both of these things generally are going to have relatively slow onset. Again, if somebody like sleeps funny or is doing a lot of repetitive stress type motions, that might have a more sudden onset. But if you really dig deep in the conversation, they're going to tell you stiff and maybe a little tiny bit achy for a long period of time leading up to that, at least stiffness. Okay. So what seems for some people like to be sudden onset, actually the pain was sudden, but the stiffness or lack of range of motion was probably cooking for a period of time, like weeks, months, years. All right. So your basic assessment is going to be exactly the same. With kind of one difference. For these, the balance method distal treatments, which I call channel balancing points, are going to be more effective. These are more effective. And so one of the first ones that I look at are points along the wrist and hand. And the other points I look at, like the sort of the a la balance method channel balancing, are points along the liver and kidney meridians, obviously on the legs, from the ankle crease working proximally up to about 6 or so sun. I don't want to get like too much into it now, but if you look at like your meridian chart that I gave you back when we were covering the balance method channel balancing, right? You know, liver balances gallbladder, liver balances small intestine, kidney balances bladder, kidney balances large intestine, kidney also balances, what was the other one? It balances lung, it balances bladder, it balances heart, and by some extension, small intestine as well. So, oh, and gallbladder, gallbladder. So basically like liver and kidney, those channels balance a lot of the meridians that go through the neck, long story short. Okay, and you have that in your meridian guide. All right. So what I generally use is, I left it at work, but I have this little tool. I kind of inherited it from my old man who was a dentist. And it was like a metal rod about this long. And it had like a little ball at the end, like you see at the end of those pointer plus. It was like a little bit of a probe, but not sharp. It was very dull. But you can use your finger. And I would probe into these points along, like just behind the, where the liver channel is, like behind the tibia, and then also down along the kidney channel, starting from the ankle crease, moving proximally, and then I mark out each one that's tender. And usually don't see much tender beyond 6 sun proximal, right? Palpation's a little bit less reactive for the arm. I don't know why, but people really feel it on the legs a lot more than the hands and arms. So, you know, you palpate here and they're like, yeah, it just feels like pressure. Yeah, it just feels like pressure. Yeah, it just feels like pressure. Yeah, blah, 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 right? You don't really get a lot of reactivity here. But boy, when you're palpating the legs, whoo, yeah, baby, people are like jumping. And I think like the more, this is just me, I think like the more distal, the better. So obviously people's feet are further away from their neck than their hands. Which is not to say that you're not going to get a lot of bang for your buck with these, but I seem to get a lot of benefit from those. So soft tissue damage, quasi-sudden or chronic onset, you know, your treatment strategy is going to be basically dispelling any kind of external pathogenic factor. You're going to be also maybe engaging in like dealing with points for the internal pathogenic factor, which would be like your spirit points or your mental level points, right? Because a lot of this might be stress. I mean, this is like repetitive stress. You know, people are like constantly at the computer, they're constantly getting stressed out, they're hunching up, right? That's in a way repetitive stress. So resolving, clearing EPFs and IPFs, rectifying the Zheng-Qi, this is on page 8. Rectifying the Zheng-Qi via points on the primary channels. The sinew channels can be helpful here, especially if there's a lot of like a lot of pain or recreation of pain with the sinew movement evaluation tests, right? Or there's a lot of pain with the primary meridian movement evaluation tests, then I treat those first. Basically, when I'm doing these like So clearing external pathogenic factors, doing points for the internal pathogenic factors, their mind, their spirit, right? And then now I'm deciding like on what channel level do I treat. Basically, what I treat next or earliest and most frequently and first in the treatment is basically which test creates the greatest recreation or aggravation of pain or discomfort, right? So let's say I do a primary meridian test and that aggravates it maybe 4 out of 10, but I do a sinew meridian test and that aggravates it 6 to 7 out of 10. That's what I'm going to do next. That's what I'm going to do first. Does that make sense? So, you know, you're going to go through your tests and you're going to note what seems to be the greatest, what seems to provoke the greatest discomfort, what seems to be the greatest aggravant to their quality of life. So maybe the wind cold signs and symptoms based on pulse and tongue and symptoms and other signs, that seems to be like the most egregious. So those are the points that I'm going to treat first, right? If it's the primary meridian movement tests that provoke the most discomfort, that's what I'll do first. If it's the sinew meridian evaluations that provoke the most discomfort, that's what I'll do first, right? If it's the foraminal compression test, right, that tests the neck extensors, then maybe I do some distal points that relate to those muscles or that area, as well as some like cupping or gua sha and maybe some Usher points or motor points for the neck extensors. Does this make sense? That's how you order what to do first and what to do next. This made it an 8 out of 10. I do that first. This made it a 6 out of 10. I do that second. This made it a 4 out of 10. I do that third. If I can get them down to 50%, that's good. Like that's enough for most people. Yes.
When would you use the balance method over the other ones, or is that just later down the line?
So the balance method, I would use primarily where there's a soft tissue injury or a trauma that's like to a limb or an area of the body where there's not radiating pain.
Okay.
Where the channel flow, the flow of qi and blood through that channel seems to be obstructed, which shows up as changes in temperature, an inability to perform certain movements, changes in tonicity, or a lot of Usher along a meridian trajectory or the area between the trajectory of two meridians. So basically for everything that isn't radiculopathy. And unless, you know, again, I would go to it first if like my primary channel level tests are the most positive. I would do the tonification points, or if they don't work, the sedation points. Then I would do balance method channel balancing points, because these balance method points, the channel balancing, is for a primary channel disharmony. So if the primary channels and their movements or I'm palpating along that trajectory and that's like the most tender and the most Usher, then I would do, you know, channel balancing treatments first, right? Tonification points or sedation points along with balance method points. If the pain from that is greater than the tests for the sinew meridians. If it's a tie, I always go with the sinews first because the fascia surrounds the muscles. It's a more superficial phenomena. And it also involves the Wei Qi, which also has the extra benefit of protecting and armoring the person against successive pathogenic external pathogenic factor invasions. So it does a lot. So Tai goes to the sinew meridians. That's generally where I start first, unless there's some other test that provokes a greater aggravation of pain, right? And you can use that in all situations, chronic, acute, with trauma, without trauma. You know, somebody looked at them funny and they got upset, sinew meridians, you know what I mean? They're powerful treatments. Does that answer your question, Brittany?
Yeah, thank you.
Okay, all right. So again, the list and the order of that list I've given you as a basic guide in terms of treatments. I generally, again, whatever seems to be aggravating the condition the most, that's generally what I treat first. So you've got a whole list of assessments. You're going to keep track of which one is the most egregious, and that's at the top of your list. And then that's going to be your primary treatment strategy. So let's do an example. I realize it's late. I'm sorry, time got away from me. So any of you have neck pain? Okay. So I'm sure you've probably tried some of these sinew meridian movement evaluations, primary channel movement evaluations. According to your memory, any of those generate a positive result? That is, recreate some kind of pain.
So chin to chest with more like leaning to the left causes a lot more pain and discomfort on the right.
Okay. So this tests the small intestine and heart primary channel. Okay. That's also a type of like flexion extension. So that might involve the sinew of the bladder. Okay. Although it could also be considered retraction. So that also might be heart, right? So we're looking at potentially heart, small intestine primary, bladder, heart, sinew. You've pointed to the area of pain, that's small intestine. Then I would palpate that area, go into, is it, what makes it better? What makes it worse? What makes it better? What makes it worse?
Heat makes it better.
Okay, which implies cold. Is it achy or sharp?
It's ache. It's really ache, like a deep ache.
That's more chi. Okay. Is it better or worse with stress?
I haven't noticed a difference with stress
Or mood?
because I probably am at a constant level of stress.
All right. So
I do notice it worse in the morning.
Right. So that implies yang qi. So that implication then implies yang qi deficiency. It's worse with cold, better with heat. That implies tai yang. Tai yang is small intestine bladder. It hurts a lot doing this. So that again is small intestine. It hurts along the small intestine channel. So we're building a case for tai yang small intestine predominance. So I would then say, okay, you know, based on that, like I would do maybe the small intestine sinew and primary channel treatment first. So I would do like small intestine 1 on your right, with then gallbladder 13 and or stomach 8. And then I would have you move and see if it's any better. And if not, then I would add maybe the primary channel treatment, which would be the tonification point, small intestine 3, heart 9, which also has the added benefit of the heart sinew meridian. So you're kind of getting 2 with 1, right? Then I'd check to see if that's better. If it's better, we're good. Then I might do maybe just some local liniments that are warming and send you home with some shoulder shrugging exercises. Maybe some other exercises to kind of like work the neck extensors, right? If you come back and say, yeah, that was good for a little while, but it didn't hold, then it suggests to me that maybe the posture is not changing. So we need to up the exercises to shift the posture and to work the muscles in charge of the posture and movement, right? The phasic and postural muscles. Then I might do the small intestine 15, 14, and 13 with or without E-stim, right? And then I might do some cupping and or gua sha on that. And while the cupping and gua sha is going, I'd probably put in like a few, Dr. Tan or Master Dung distal points. So like while those are cooking, while the cups are on, then I might, you know, palpate along the liver and kidney channels of the legs, maybe pop in a couple points there and have you like see what that's like, right? If you have radiating pain, then I would add the Huatou Jiaji points and Asher points, or important points like small intestine 12, like these, you know, external pathogenic factor invasion type points, and qi and blood moving type points along the trajectory. So that might be small intestine 12 to clear the wind, bladder 12 to clear the wind. Palpate along the area. Maybe small intestine 10 is uncomfortable, or 11. I might do those if I'm sure. I would definitely do the G clef point on small intestine, right? And then maybe even involve some of like, what do you call it? Like maybe even some large intestine points just upon palpation if they're pretty rough, right? But yeah, I would do like then points down the trajectory, and then end with small intestine 1, again to clear out that external pathogenic factor, right? Does that make sense? So just something really simple like that, right? And then whatever test aggravated you the most, that's where I'd start. All right.
Meaning the primary channel versus the sinew channel.
Right. Yeah. Like if you know, again, if the sinew channel, like, you know, like if I do this with the sinew channel, like we have you move your arm back, does that hurt?
No change. No.
How about if you're just like extending out? Extending out?
A little tightness with extending out.
Right.
Like it's pulling.
Right. Because your scapular probably in retraction, so that extension is probably aggravating. But it's a little pulling. It's not like, oh God, that really hurts.
Yeah,
right?
no.
Like this is like, wow, that really hurts. Like that's primary. So I would start with that. Right. And then I would look, you know, for signs of like wind, cold, damp invasion, or wind or cold, or wind, cold, or wind, cold, and damp, right? That's B syndrome. Then you can do some, you know, systemic points for that, as well as maybe some local points, maybe even like bladder 10, small intestine 12. If it's more like, but you said it's more constant, so that's not really wind. So it's probably cold with wind and maybe a little damp, right? Because it's in this vague area, which is kind of damp, but then every now and then you move a certain way and you feel it kind of like fixed in one spot.
Yeah.
More severe. So that's cold, damp wind. Right?
Is that cold B syndrome then?
Yeah, yeah. So cupping, local moxa, invigorate. But you know, if you don't have time for all that, cupping, vigorous liniment application that's warming, right? Like some ditat jiao that's like more hot in nature, or like what's it called? Tiger liniment.
Okay.
Right?
I have some of that.
Yeah, just like rub it in there.
Okay.
And then you know, while that's going, I could do the channel points, right? Tonification on heart and small intestine, and then if that didn't really do it, then I go back and then do some distal points, maybe along the ankle, maybe along the wrist, right? Small intestine treats small intestine same side. So if it's right, I do some small intestine points along here, right side. Right? Bladder, opposite side, kidney, opposite side, liver, opposite side. you know, and that's probably what, 8 points. You can also like go back and do like Moxipol over it, you know, depending on how much time you have in your treatments, right? Or you can get like one of those hydroculator packs, put that on there. That's real nice. You know, put the
I have
liniment
no
on.
idea what a hydrocular pack is.
You can look it up. It's basically like a
Okay.
hot pack. It's like a moist heat. It's moist heat.
Gotcha.
Yeah. Somebody who speaks well in a moist, damp environment is a hydroculocutor. All right. So, but yeah, you can put the liniment on, then just like some moist heat, like over top of that. It's real nice. And then prayers.
Can't underestimate the value of that.
No, sir. No, ma'am. All right. So again, you know, this like sort of neck extension and flexion, like that might imply Tai Yang, right? So that's small intestine bladder. So you see how things like start to like, oh yeah, like there's a theme that runs here. And then I would go into, you know, like, okay, so what does Tai Yang represent in the world? Our ability to extend out into the world, right? To bring the power of our will, the kidneys, and the desire, the appropriate desires, the authentic desires in our heart out via the small intestine and bladder, right? Out into the world to extend our will, to extend our Shen, the things that we care about, out into the world to create some kind of effective change, right? Right? That's that like, you know, water to feeding wood to feeding fire movement. So then I would ask into that, are you retreating too much? Are you holding back too much? Again, you don't have to answer this, right? But these are the questions that I would ask. Or, you know, ask into the correspondences of the small intestine and the bladder. Do you feel like you're managing your resources well, your time, your money, your energy, your attention? Do you feel like you're overwhelmed? Do you feel like you're actively just kind of treading to keep your head above water? Do you feel, that's bladder, right? So small intestine is like, is there enough lightness of being in your life, right? Okay. And people wonder why they like walk around like this. I'm overwhelmed at work. I got so much to do. It'll never freaking end. And like, it's no fun. And I haven't. But I'm fine.
And I'm going to graduate in December and I have no freaking clue what life's going to look like then.
Well, nobody actually really knows what their life's going to look like anyway.
Right.
Right.
The people who are like positively deluded. Right? But I get it. Like, but there's like more uncertainty than you can bear. Yeah.
And
so
no joy.
Yeah, and stick this out and then go like that. How's that? Now don't go like this, like this.
Just the no change.
Okay, so that's Xiaoyang, right? And then bearing weight, gripping, holding, bearing weight. That's
so the resistance is like the extending. That can feel a pull, but it's no pain.
Yeah. So, you know, the last things that I was talking about, this leads you to do certain spirit points, right? Maybe you do a window of the sky point. Maybe you do some point whose name resonates with, or elemental nature resonates with the issue at hand. So maybe the fire in the fire and the fire in the water, right? You know, small intestine 5, small intestine 5, heart 8, you know, bladder 60. No, heart 8's fine. You just put it in quick, then it's fine. It's no big deal, right? Bladder 60, kidney 2. Any hot flashes, sweating at night?
Oh, yeah.
Oh, yeah, you got to do kidney 2. Yeah. Okay. All right. So we're 2 minutes over. I apologize. So that's that. So I'm going to try. I really want to. I'm committing my intention to treating some Huatou Jiaji points and making a videotape of it, like a very short recording, like a minute long, to show you what I mean. it's just been really challenging. Like I've had last 2 patients I wanted to do it on, for whatever reason, they didn't want me to like record them. So, because they have tattoos on their backs that kind of identify who they are. And one person's somewhat well-known. So that didn't like, you know, I was like, okay, fine, we'll keep your privacy. So I'm going to really work on, you know, getting a video recording of that. We're going to go over those over and over about the Taiyang and the implications of that. I think I have it written up somewhere. I'll look for it and post it for you. Like the psychospiritual, psychological connotations and resonances of the 6 divisions.
Thank you.
All right. I know that's a lot. I'm sorry we went over time. I'm 3 minutes over. So if you have any questions, and I'm also happy to open the conversations, you know, just let me know. Not a problem.
Thank you, Time.
Thank you, Time.
Take care.